So we'll start with the today's topic. So nasopharyngeal carcinoma has a unique biology, epidemiology, and the behavior. It is not the common carcinoma seen in our country. However, it is important because it's a highly curable tumor if detected and treated properly. Nasopharyngeal carcinoma has a particular etiology and epidemiology. It is commonly seen. The endemic areas are places like China, that's especially southern China, Southeast Asia, and areas in the Mediterranean, which are known as endemic for this tumor. Also, there are certain biological, genetic, as well as other factors such as EBV infection, which make it endemic in these areas. The pathology, there are three main histological types described. One is the well-differentiated squamous type, which is the less common type. The others, which was previously labeled as WHO grade 1. Then the poorly differentiated and the undifferentiated. The undifferentiated type is the most common, and especially in endemic regions where EBV infection related is the cause for the pathogenesis, it's the most common type. In non-endemic regions, it is slightly less common, but it's still the most common histology, seen up to 75% in non-endemic region, but it can go up to 95% in endemic regions. The important thing is, if it is detected early, it is highly curable. With the stage 1, cure rates are more than 90%, reaching up to 95-96%. The problem is because of the location of the anatomical location of the primary tumor, it is often detected in late stagings, and prognosis in metastatic disease remains poor. So a little bit about the pathogenesis. There are certain factors which are associated with the pathogenesis of nasopharyngeal carcinoma, and it is one of the carcinomas which is has a strong association, or EBV is the viral driver for this tumor. So there are other carcinogens also noted in places, especially in the endemic area like South China, which is the use of salted fish, which has some nitrosamines. But however, with the awareness, the use of these foods are decreasing, and the incidence also has started decreasing in these regions. This is a figure which is showing an overview of the hypothetical model for pathogenesis. So as we know, in the non-malignant nasopharyngeal epithelium, some chemical carcinogens, it might be the food like salted fish or other carcinogens, can cause early genetic lesions, especially in the cyclin and RB1 pathway, which is a tumor suppressor pathway. And you will see mutations in the cyclin-dependent kinase 2 genes. And at the same time, infection with EBV, along with these mutations, lead to carcinogenesis, and the loss of certain genes also predisposes these patients to have latent chronic EBV infection, which leads to further carcinogenesis. Now, the important thing in the pathogenesis is the latent infection with Epstein-Barr virus, which allows all these oncoproteins to be expressed, as well as non-coding RNA in the cell. And both these proteins as well as non-coding RNAs have an effect on the epigenetic through epigenetic mechanisms, and cause changes in the DNA, as well as they not only drive genomic instability, but they also cause hypermethylation of tumor suppressor genes, and they cause these epigenetic silencing of these genes. So as a result of which, a lot of tumor suppressor genes are inactivated, and the clonal expansion of these EBV cells starts. Slowly over time, there are other acquired gene mutations which develop in these pathways. Some of them, like mutations in the MHC class 1 gene, help the tumor cells to undergo immune escape, so they can escape the immune system and continue to grow unchecked, and then ultimately they will form invasive carcinoma and start spreading. So this whole process of latent EBV infection and the genomic instability and inactivation of all the tumor suppressor genes then invariably activates all the cancer hallmarks and leads to the development of the nasopharyngeal carcinoma. So the first step is, how will you evaluate a patient with suspected nasopharyngeal carcinoma? Usually the clinical presentation, what we commonly see would be a nasal obstruction or a blocked nose. Also, patients who come in a locally advanced disease will have cervical lymphadenopathy, and if it's very advanced, may or may not have some cranial nerve deficits. So the first thing is a history and a proper physical examination, including the neck node examination and a mirror examination. we do a nasopharyngeal fiber optic examination, which we say as a DNE, which is a direct nasal endoscopy. A biopsy, either of the primary, or if there is a large neck node mass, there can be an FNE or a biopsy from that mass. And important, especially for treatment planning and for radiation planning, is an MRI from the skull base to the base of the neck. And most important is the need to see skull base erosions. For patients with higher nodal stages or large tumors, that is when you come to T2, T3, T4, and N2, N3 disease, a PET CT is also done to rule out distant mets, because the patients with bulky tumors and nodal N2, N3 disease have high incidence of having a distant mets. EBV DNA testing is done. In our hospital, we do it both by the RT-PCR to quantify the DNA, as well as on IHC on IHC also for LMP1, and IBER-ISH can also be done. Most important are also these things which are not for diagnosis, but play a very important role in the treatment. One is we have to consider ophthalmologic and endocrine evaluation, because the nasopharynx is in close proximity to critical structures like the optic nerve and the pituitary gland. And many times the patients who receive radiation, despite improvement in radiation techniques and routine use of IMRT now for nasopharynx, this is important because you need to know if there is a field defect or a problem at the baseline, as well as we need to monitor the patient's post-treatment for endocrine, especially hypopituitarism, and for visual field defects. And audiogram, many times we see conductive hearing loss in the affected side. That is because of the eustachian tube from the ear which connects the middle ear, and because of that there is conductive hearing loss which improves after the tumor is treated. But we need to know also whether there is a sensory neural hearing loss, because we need to plan cisplatin based therapies. So these are the things. Since a lot of these patients, especially in endemic areas and in the younger age group, fertility and reproductive counseling should also be done, and a dental evaluation pre-radiation. Overall, we divide it into very early, that is T1, N0, M0, that is stage 1 disease, or a locally advanced or a metastatic disease. And this is broadly divides the treatment approaches. So this is the staging. So if the tumor is only confined to the nasopharynx, or it goes into the oropharynx or the nasal cavity, it is limited to stage 1. If the tumor goes into the parapharyngeal space or the adjacent soft tissues, that is the medial lateral pterygoid muscles and the prevertebral muscles, it is T2. This is an update from the AJCC 7, where these structures were previously labeled as T4. And the bony, easy to remember, is bony structures at the skull base and bony structures around the nasopharynx, like cervical vertebra, pterygoid bones, or paranasal sinuses, will be T3. And any intracranial extension, cranial nerve involvement, tumor coming down up to the hypopharynx, going beyond the lateral surface of the lateral pterygoid muscle, involving the orbit of parotid, is T4. For the nodal staging, a landmark which is used is the caudal border of the cricoid cartilage. So the N1 is unilateral mets in the cervical nodes or the litopharyngeal node. It should be less than 6 centimeters in size and should be above the caudal border of the cricoid cartilage. Bilateral mets 6 centimeters or smaller, again above the caudal border is N2, and any node more than 6 centimeter or below the caudal border of the cricoid cartilage is N3, which is known as the N3 disease. So stage 1 is T1, N0, M0. Stage 2 includes T0 to T2 tumors as well as N1 tumors. Stage 3 will include T0 to T2 tumors with an N2 node, or a T3 tumor with a N0, N1 or N2. Stage 4 are two things we have to remember: stage 4A and B. Stage 4B is any metastatic disease, and stage 4A is T4 tumor with N0, N1, N2 or N3, and any N3 node, that is any node more than 6 centimeters or in the lower neck, will be stage 4A. So this is, I've already discussed the changes from the 7th and 8th. So broadly, this is how the NCCN divides it. Early stage, very early stage, which is not so commonly seen in our routine practice, is to give RT to the nasopharynx and RT to the neck. Node positive disease or higher stage tumors, there are two approaches. One is either you can give induction chemotherapy followed by chemoradiation, or chemoradiation followed by adjuvant therapy. And metastatic disease, either systemic therapy or clinical trials. After systemic therapy, depending on whether it is oligometastatic disease, with a good response, some patients may be offered consolidation RT to the primary and to limited metastatic sites. Otherwise, we observe them after systemic therapy and give second-line therapy at progression. So role of chemotherapy in nasopharynx, as discussed, it's in 4 settings. One is concurrent chemotherapy. Second is neoadjuvant or induction. Third is adjuvant. And fourth is the palliative setting. So these are the systemic therapy agents. In addition to chemotherapy, in the recent years, there is a lot of ongoing research on various immunotherapy agents, as well as immunotherapy agents for nasopharyngeal carcinoma. Also, certain situations like in third line or second line setting, targeted agents against EGFR have been used, like cetuximab. So we start with, we'll go through each of these in a sequence. So induction chemotherapy, adjuvant chemotherapy, and chemotherapy in the metastatic disease. So to start with, in stage 1 disease, that is T1N0, the patients with stage 1 do very well with RT alone. So 5-year OS was more than 90%, even in older studies, as old as 15 years old, where they give conventional RT and not IMRT. Now these outcomes have improved. But moment there is a larger stage or a T2 lesion or N positive, the outcomes worsen. So you can see the disease-specific survival, recurrence-free survival, distant met survival comes down. And that is where the chemotherapy, actually the studies with chemotherapy started coming about 15 to 20 years ago. Prior to that, radiation was the only main therapy used. Surgery in a newly diagnosed case of nasopharyngeal carcinoma doesn't play a major role, mainly because of the anatomical location of the tumor, where doing a primary surgery with critical structures can be difficult and lead to deficits. So radiation was the main treatment, and as time has evolved, it has moved on to multimodality treatment, which includes induction chemo or chemoradiation, or chemoradiation followed by adjuvant chemotherapy. So what they saw is, by adding chemotherapy to radiation alone in patients with stage 2 disease, the outcomes became equivalent to stage 1 disease. And these were early trials 20 years ago. Around this time, lot of studies happened where they included patients and they compared RT alone with RT with concurrent chemotherapy, and that is how concurrent chemoradiation became the standard of care after that. So this was a study which was published in 2011. This was done in China, and it was classified as per the Chinese staging, where patients were randomized to RT alone, which was a standard of care at that time in the late 1990s and early 2000s. And cisplatin weekly was added to RT in the other arm. And what they saw is at 5 years, there was nearly a 10% improvement in overall survival, nearly a 10% improvement in progression-free survival, and distant metastasis-free survival. And the addition of concurrent chemotherapy significantly improved outcomes in all the parameters, that is OS, PFS, and distant metastasis-free survival. The loco-regional survival did not change much. But if you look at this over time, all studies more or less have similar results, where the addition of systemic therapy or in form of adjuvant or induction show improvement in these 3 parameters. But loco-regional relapse-free is usually similar, because loco-regional relapse-free, the local disease is well controlled by RT, but the poorer outcomes in nasopharynx is because of the distant metastasis, and it has a propensity to metastasize early, especially in node-positive disease. So this was one of the early studies which showed the benefit of chemotherapy. Subsequently, there were many other studies where they used different schedules, like this used 5-FU and cisplatin along with RT, and all showed that they had better outcomes than using RT alone. So after that, RT alone went out of, in patients with stage 2 and above disease, went out of vogue, and chemoradiation became the standard of care. So as I already discussed, chemoradiation, addition of chemotherapy didn't change the loco-regional failure-free survival, but it improved the distant failure-free survival and overall survival. This is an important study which I will discuss again when we discuss about adjuvant chemotherapy. This was the Intergroup 99 study, which was published in 1998. And this was another study which evaluated the role of chemotherapy concurrently and with adjuvant chemotherapy as compared to RT alone. And the overall survival, there was a 31% improvement in patients who received this concurrent plus adjuvant chemotherapy as compared to RT alone. So this was one of the early studies. Then after this, the use of chemotherapy in nasopharyngeal carcinoma became standard of care. So chemotherapy regimen, the standard chemotherapy regimen is cisplatin. Cisplatin in most of the studies is used as 100 mg per meter square initially, including studies which had induction as well as adjuvant chemotherapy. But there were other studies which were done to show that weekly cisplatin was not inferior and it was easier to administer and the quality of life was similar. So very often, if we in our settings, we use weekly cisplatin for the ease of administration and the better toxicity profile. So both regimens are acceptable: 100 milligrams per meter square 3 weekly, or weekly 40 mg per meter square regimen, which we commonly use in patients who have received NACT. Carboplatin plus cisplatin or cisplatin, which is the better platinum? Standard of care is cisplatin. Most of the studies which are done in all parts of the world, including the endemic and non-endemic areas, have used cisplatin, and it has significantly improved outcome. However, there have been studies which have used carboplatin and oxaliplatin as well. Now, this is one, for example, where carboplatin was used with cisplatin. Carboplatin has almost similar overall survival in the intention to treat population, though here cisplatin for the disease-free survival appears to be superior. But the authors concluded that carboplatin could be used because it has better tolerability and the outcomes are not so inferior as compared to cisplatin. So in patients who are really unfit and cannot receive cisplatin, carboplatin may be considered with concurrent radiation as well as as a part of the DCF regimen. So this is a simple table showing the side effects, and we know that cisplatin has higher nephrotoxicity and nausea, vomiting, which is less with carboplatin. Now, the important development in nasopharyngeal carcinoma was the use of additional chemotherapy, that is either concurrent neoadjuvant or adjuvant. So there are mixed results. Initially, the older studies had a lot of mixed results, and there was a lot of controversy about the use of neoadjuvant chemotherapy. But now the more recent studies, especially the study which was published in 2019 with in NEJM with the gemcisplatin, showed there was a definite benefit in the overall survival. So now induction chemotherapy has been accepted as a standard of care in some parts of the world, whereas some still continue to use adjuvant chemotherapy, and both options are being considered acceptable now. So the reason for using adjuvant or induction chemotherapy is because we noted there was a lot of distant failure, as I mentioned earlier, with patients with node-positive disease. And concurrent chemoradiation had very good loco-regional control, but a lot of the outcomes worsened because of distant mets. So the main advantages of using NACT in carcinoma of the nasopharynx is it improves survival because eradicating distant mets. It has, in patients who are planned for radical treatment, that's chemoradiation after NACT, because the tumor volume decreases, there is better tumor coverage during radiation. And also it is easier to complete complete the 3 cycles planned NACT rather than complete 3 cycles of planned adjuvant therapy, because after CTRT, the patient's nutrition profile, toxicities of CTRT lead to mucositis, nutrition profile and fitness is compromised, and they don't complete CTRT. Some of the major adjuvant chemotherapy trials have shown that only 50% completed adjuvant chemotherapy after CTRT, as compared to the recent GEMSIS trial, which showed nearly 97% of the patients were able to receive 3 cycles of planned gemcitabine and cisplatin. So more likely to complete treatment and receive the full dose of treatment. And a very important aspect is critical neural structures can be spared during radiation because the tumor volume will decrease and the radiation can be planned sparing these structures. So this is an early phase 2 trial which showed the benefit. In this trial, they used OCCIS as the neoadjuvant chemotherapy, and they showed that in patients who received neoadjuvant chemotherapy and subsequently underwent concurrent chemoradiation, the CR rates and the ORR rates were much better than those who received concurrent chemoradiation alone. And these were the progression-free survival and the overall survival curves, where you can see that NACT improved both of them. Now, this is another important trial from China. This trial included DCF, that is docetaxel, cisplatin and 5-FU as NACT, followed by CTRT with cisplatin 100 milligram per meter square. That was the experimental arm, and the standard arm was concurrent CTRT with cisplatin 100 milligram per meter square, and IMRT was used in both arms. Again, the primary endpoint was failure-free survival, and failure-free was defined as any failure, that is locoregional failure, distant failure, or if the patient died due to any cause. And these are the outcomes. And you can see here, this is the primary outcome, which is failure-free survival at 3 years, which they looked at, which was significantly improved by addition of chemotherapy. This was overall survival, which was again significant. Again, this was distant failure-free survival, which was significantly improved. And this was the locoregional failure-free survival, which was slightly better, but not significantly better than the concurrent chemoradiation group. And this showed that the addition of DCF as induction or neoadjuvant chemotherapy improved outcomes in patients of nasopharyngeal carcinoma. Now, in these trials, stage 3 and 4 non-metastatic patients were included. And metastatic patients were usually excluded from such trials. Toxicity, as we know, if you add a regimen like DCF, we expect higher toxicity, especially hematological toxicities, which are neutropenia, which was the most significant toxicity. CTRT toxicities were similar. They did not significantly vary between the two groups. And these are the failure-free survival and the overall survival curves. And it was an acceptable toxicity, but the significant improvement in the failure-free survival and also an improvement in the overall survival. But at the same time, as I mentioned earlier, the older studies had mixed results. That was a study which was positive and showed a significant improvement in most outcomes. This was a study done in Taiwan. However, this was a different regimen used, where they used mitomycin, epirubicin, cisplatin, and 5-FU. And this was a negative study. It showed that there was an improvement in concurrent with the use of concurrent chemoradiation for induction prior to concurrent chemoradiation. They showed that there was an improvement in disease-free survival, but overall survival didn't improve significantly. So that is the reason why initially in the past there were mixed opinions about the use of NECT. This is a recent trial on induction chemotherapy, which was published in 2019. They used high-risk patients, that is T3, T4 disease, and including N1, N2, and N3 disease. So stage 3A, 3, 4A, and 4B were included. And this also showed improvement in outcomes. So this was the primary outcome, that is recurrence-free survival. Again, they described it as recurrence-free survival in patients with any recurrence. It might be distant recurrence, locoregional recurrence, or death due to any cause. And it was significantly better in those who received gemcisplatin followed by chemoradiation as compared to chemoradiation alone. That was the standard arm. Also, the overall survival was better in patients who received induction chemotherapy, and the distant metastasis-free survival at 3 years was better. The locoregional survival was same. So this is the curve showing the primary endpoint, where locoregional recurrence-free survival is better with the use of gemcisplatin as induction therapy. And these were the secondary endpoint: overall survival, distant recurrence-free survival, and locoregional free survival. So this study showed that was an improvement. In contrast to another study which was done in the past, where they used gem-carbo and taxane, but this is a more recent study. They used higher risk patients at what we commonly see in our clinic, that is T2, T3 disease with N2, N3 disease, and hence the benefit was seen. Whereas some of the older studies which use similar regimens included the lower risk patients, and hence the benefit of induction chemotherapy was not seen as much. This is another study which again showed an improvement. This is a long-term 10-year follow-up outcome, where there was an improvement in disease-free survival and distant metastasis-free survival, and it was significant. So there have been multiple meta-analysis which have been done, but the results of the meta-analysis have varied, because they have used trials from different phases and different regimens, and different combinations used, so they are not uniform. Some of the old meta-analysis used older trials, so that is why the benefit of induction chemotherapy was not so evident. Like one of this showed only a trend towards significant improvement in the overall survival with use of TPF, and there was no difference on OS in the study. But then the criticism is that they are heterogeneous studies were included, and they were older studies. The studies after 2017 were not included. An important meta-analysis for nasopharyngeal carcinoma was the MAC NPC. Initially, it was published in 2009, then it was updated in 2015, and now it has been updated again in 2020. So these are the 2015 results. And here, they showed that there was no significant benefit in overall survival or progression-free survival with induction chemotherapy followed by concurrent chemoradiation versus concurrent chemoradiation. But again, like I discussed, only 2 trials directly addressed that question. And then there were other trials which were excluded, which were published after 2015, which showed definite benefit of neoadjuvant chemotherapy. Also, some of the statistical techniques also have been questioned in this. So there has been an update now. The recent update, which was presented in ASCO, showed that the taxane-based induction chemo, that is DCF, docetaxel-based induction chemotherapy followed by concurrent chemoradiation, was the best treatment sequence for overall survival when they compared it to chemoradiation alone, and the hazard ratio was 0.75. So recent studies, since they have shown an improvement in overall survival with induction chemotherapy, the updated MAC NPC has also reflected this benefit. The other approach is to give adjuvant chemotherapy in locally advanced or loco-regionally advanced nasopharyngeal carcinoma. This approach evolved just like how NACT evolved, because IMRT improved the loco-regional controls significantly as compared to 2D CRT, which was used in the past. But it did not have any impact on the distant mets, and the outcomes still were not so great in patients with N2, N3 disease. And that is how the adjuvant chemotherapy approach came about. This was the study I had mentioned earlier. This was the intergroup study where they had 2 arms. That was RT alone arm, which was 70 gray, and the RT plus chemotherapy arm, followed by adjuvant chemotherapy. Here, the chemotherapy was cisplatin, which was 100 milligram per meter square given along with radiation. And in the adjuvant setting, it was cisplatin with 5-FU, which was 80 mg per meter square of cisplatin and 1 gram of 5-FU for 4 days. And this was given every 4 weeks for 3 cycles. So you can see there's a marked difference in patients who received RT alone and RT followed by adjuvant chemotherapy for both progression-free survival as well as overall survival. And there was a 31% improvement at 3 years, and this was maintained even at subsequent follow-ups, that is at 5 years. So at 5 years, you can see the disease-free survival, progression-free survival is almost double. The disease-free survival is nearly double, and even there's a 30% improvement in the 5-year overall survival. However, comparing this trial to our modern day trials, we know now that RT alone is not the standard of care anymore. It is so all the subsequent trials have used chemoradiation with adjuvant chemotherapy as the background. So this is also another older study which used RT versus CTRT followed by adjuvant therapy, and this was also similar to the intergroup 99 trial, which showed the benefit. But there was only one thing, is there was no benefit of OS in this study. So similar to NACT, the earlier studies for adjuvant chemotherapy also showed mixed results, and hence there were controversies about the role of adjuvant chemotherapy and how much it actually benefits and in which patients. So this is another study which was published. This was done predominantly in China, where they used 5-FU cisplatin followed by as adjuvant chemotherapy following concurrent chemo, where they use a regimen we commonly use, that is weekly cisplatin. And they also took stage 3-4 patients except T3, T4 tumors with node negative patients. Again, the use of adjuvant chemotherapy improved the failure-free survival rate at 1 year and 2 years. Also, there was better overall survival, but this is in contrast to the intergroup 99 study, where there was not a significant difference. There was a slight improvement, but if you look at all these curves, they are very close to each other, and none of the p-values are significant. So this is again one of the negative studies for adjuvant chemotherapy. So the older studies for adjuvant chemotherapy were variable. Few studies showed a survival benefit. Few studies did not show survival benefit. Many of the patient studies did not focus or stratify the patients included properly. That is, they did not include or divide the patients into nodal status, N3 disease, or bulky primaries. So that is why we have these mixed results. However, now there are newer strategies being developed for adjuvant chemotherapy. So the other issue with adjuvant chemotherapy, which I had discussed earlier, is the number of patients who are actually able to receive adjuvant chemotherapy, which in many of the studies were only 50 to 55%, and nearly half the patients did not receive all the planned dose. So the treatment intensity was, and the dose intensity was not maintained in many patients who received adjuvant chemotherapy for multiple reasons. Mainly post CTRT, patients were not fit enough to receive the aggressive adjuvant therapy regimens. So there are new strategies that have been developed for adjuvant chemotherapy. These are the two studies which were presented in ASCO this year, where they use capecitabine in the adjuvant setting for high-risk nasopharyngeal carcinoma. They used as a standard dose, that is 1000 mg or 1250, like we use in many other tumors of capecitabine, and also a lower metronomic dose of 650 milligrams. And both studies showed that it improved the outcomes. So this is the first study where they included high-risk patients. So these studies, if you note, in contrast to the previous studies, are properly selected patients where they had high-risk patients. So they had stage 3 to stage 4B as per AJCC 7, but they had to have any of these high-risk features, that is T3, T4, N2, or T1 to T4 with N3. They had to have high EBV DNA. EBV DNA has a very strong prognostic value, though there is still no therapeutics predictive value for therapeutic stratification, or trials are ongoing to see how we can intensify treatment based on the EBV DNA value. But everybody has accepted that EBV DNA values of more than 4,000 usually have associated with higher recurrence and lower survival. So they have taken patients with EBV DNA of more than 20,000 copy numbers, large tumor volumes, and higher SUV uptakes, and any neck node mets more than 4 centimeters. And they gave concurrent chemotherapy with adjuvant chemotherapy. That was their approach. And the adjuvant chemotherapy was capecitabine, which they used as 1 gram for 14 days, every 21 days, and they gave it for 8 cycles, as compared to concurrent chemotherapy alone. The standard arm did not have any induction or adjuvant chemotherapy in this study, and the primary endpoint was failure-free survival. And they noted it was better for the adjuvant capecitabine as compared to the concurrent chemoradiation alone. And there was no significant difference in the overall survival. The loco-regional failure-free survival appeared to be better, and the distant metastasis-free survival also appeared to be better, but this is a short follow-up. So these are prelim results, and longer-term follow-up will be needed to see whether the overall survival ultimately improves. And they saw that the larger the more number of cycles the patients were able to receive, the better the outcomes were. And also, since the capecitabine is oral and it's a routinely used therapy, they found that the compliance rates were better. So a larger number of patients were able to complete these cycles. The second study included metronomic doses, where they were given at 650 mg BID for 1 year. In this study, they included stage 3 and 4 disease, but they included patients who had received NACT as well. But N0 patients, T3, T4, N0 or T3, N1, these have lower risk of disease recurrence, so they were excluded in this study. And the standard group received the standard treatment, that is cisplatin, IMRT with induction therapy. That was a standard treatment, and the randomization was after completion of standard treatment, that is either to metronomic capecitabine or to the clinical observation. And this study also showed a benefit of using metronomic capecitabine. So in all outcomes, in overall survival, in failure-free, distant failure-free, and as well as loco-regional failure-free survival. So longer follow-up from these studies are awaited. There is some cross-trial comparison and a debate on whether patients who receive NACT and then receive metronomic capecitabine had a kind of similar 3-year distant failure-free survival as to the patients who received only capecitabine alone as adjuvant therapy. So the overall survival rates were similar. So comparing the two trials, now the question arises is whether induction therapy is required if adjuvant capecitabine alone can improve outcomes, or whether it has to be, the sequence should be induction followed by chemoradiation followed by adjuvant capecitabine. So these questions need to be answered, and we need longer term follow-up of these studies. But this is another strategy that can be used in the adjuvant setting. So finally, to conclude, what is the impact of chemotherapy in nasopharyngeal carcinoma? So coming back to the MAC NPC meta-analysis, like the 2015, which I discussed earlier, the maximum benefit was seen in patients who received concurrent CTRT and adjuvant chemotherapy, followed by those who received concurrent CT-RT. At that time, there was not much benefit seen in induction chemotherapy alone. So this is what was seen. The absolute benefit in 2015, when it was updated, it was 6.3%. And those who received adjuvant seemed to have the best outcomes. But the benefit was seen in all. It was in progression-free survival, loco-regional control, distant control, and mortality. But now the 2020 update, the full paper is not available, but the 2020 update shows that if you have received a taxane-based induction chemotherapy followed by concurrent chemoradiation, you have the best outcomes for OS, followed by patients who received chemoradiation and adjuvant therapy, and followed by patients who received other induction therapies, that is non-taxane based and chemoradiation. And the ones who received only chemoradiation had less, outcomes are not as good as those who receive any of these, that is induction or adjuvant chemotherapy. So now, based on this, our approach, it provides stronger evidence for use of neoadjuvant or induction chemotherapy prior to chemoradiation. That is the approach we follow at our institute, as well as there is a stronger evidence for use of adjuvant chemotherapy after chemoradiation, where many parts of the world like China follow this approach. So both approaches seem to have a significant benefit in this meta-analysis over using chemoradiation alone in locally advanced nasopharyngeal carcinoma. Now, since this tumor has good outcomes and usually long-term survivors are seen, treatment-related toxicity becomes important, especially the late toxicities which are seen in these patients, which include xerostomia, cognitive dysfunction, trismus, myelopathy, which leads to a Lermit sign, endocrine dysfunctions, and other things like bulbar palsy, osteoarthritis necrosis, and a small risk of radiation-induced second cancers, which we need to closely monitor. A lot of improvement in radiation techniques and the use of IMRT has decreased some of these, like xerostomia and cognitive dysfunction, by temporal lobe sparing techniques, and also pituitary dysfunction, but few patients can still have, so they need to be monitored. Now, coming to the third group of patients, that is the metastatic and the recurrent nasopharyngeal carcinomas, which are commonly seen. So we know that 2/3 of the patients will have distant mets, because this is a disease which has cervical nodal mets as well as distant mets early. And out of these 2/3, again, most of them will have multiple organ mets, and 1/3 will have local or loco-regional or regional mets. And what is important to remember is half of these mets happen within the first 2 years. So closely monitoring them during this time is important. And 75 to 85% of these patients cannot be treated with local approaches, that is radiation or surgery. So systemic therapy is the only options. So we'll go through the systemic therapy options one by one. So the first and the main option here in our case, commonly used option, is chemotherapy. So there were multiple regimens, and it is a very chemosensitive tumor. So just like the induction and the adjuvant chemotherapy settings, gemcitabine, taxanes, and platinum has been used. 5-FU and capecitabine also has been used, and there has been responses. A lot of phase 2 studies were done. They have also compared different cisplatin containing regimens, but there has been not a significant difference between them. So wide range of chemotherapy agents have been used. Why do we give chemotherapy in metastatic setting? Definitely, like in the curative setting, it improves survival, it decreases the mets symptoms, and the quality of life deterioration is worsened. Worsening is prevented. Also, the other important factor is that in patients with oligometastatic disease, a lot of patients are still being treated with a radical or a curative approach, where consolidation IMRT is offered to the primary, and also radiation is offered to the few sites of oligometastatic disease. So not all metastatic diseases are labeled palliative. Some of them can be treated with a radical or a curative approach. So what is... So one of the early studies, like which platinum is better or which doublet is better, these were the early studies done in this setting, where recurrent or metastatic nasopharyngeal carcinoma, and 2 regimens were compared, gem-cisplatin and 5-FU cisplatin. And gem-cisplatin fared better, both in terms of progression-free survival and in terms of overall survival. And in all subgroups, that is in different subgroups based on the ECOG status, based on whether it is primary metastatic disease or whether it's a recurrent metastatic disease, whether it has lung mets, oligo, or multiple mets, all favored cisplatin. What is important to note is also the toxicity profile would be more favorable in patients who receive GEMS cisplatin as compared to 5-FU cisplatin. And this has become now the standard of care in the first line setting after the Zhang et al. Published this study on the use of gemcitabine with cisplatin. So again, like I discussed, toxicity profile, doses stopped because of adverse events, incidence of neutropenia, mucosal inflammation. Some were higher, like neutropenia was higher in the gemcitabine arm, but the number of patients who had to discontinue therapy was higher with 5-FU. Dose delays and dose reductions were slightly higher there. So gemcitabine cisplatin improved PFS, which was the primary endpoint, as well as OS, and it was established as the first line of treatment in this population. But other drugs have also been tried, like paclitaxel carboplatin, in smaller phase 2 studies. So this is a summary of all the chemotherapy agents that have been done, used in the metastatic setting. So gemcitabine as single agent, docetaxel as single agent. Then the common doublets that are used, that is cis-5-FU, gemcisplatin, and paclicarbo. The gemcisplatin and paclicarbo had a similar PFS that was around 7 months. And then there are multi-drug regimens which are used where they had an OS of about 16 to 14 months, which we don't commonly use these drugs. Another aspect which I wanted to discuss was oligometastatic nasopharyngeal carcinoma. Though there is a little bit of a controversy in what you define oligometastatic disease as, but some of the researchers define it as patients who have less than 3 metastatic lesions, and it should be confined just to 2 organs, and the maximum diameter should not be more than 5 centimeters. But there is a debate about this definition. The most common sites of mets in nasopharyngeal carcinoma is bone, lung, and followed by liver. So this is a study. So this is a study which has kind of shown the role of IMRT consolidation in patients with oligometastatic disease, where patients were treated with cis-5-FU induction. Those who had a response, at least a partial response, were randomized to either chemotherapy alone, that is 3 cycles of the same chemotherapy to continue, or the same chemotherapy with consolidation IMRT to be given in patients with oligometastatic disease. And what they saw was in patients who received IMRT, OS and PFS both have improved. So this is some evidence for the use of IMRT in patients with oligometastatic disease. And even at our center, if patients with limited mets, bone mets, very fit patients are sent for NACT and treated with a radical approach. The other setting, what we see is recurrent disease, that is patients who have been treated previously with a curative intent and have disease recurrence. So in this, there are 2 things other than systemic therapy that need to be discussed. That is the role of surgery and the role of irradiation. So the role of surgery is quite limited in nasopharyngeal carcinoma. Especially in the recurrent setting, it is limited to only those who have small isolated regional nodal mets who can go for a salvage node dissection, or in patients who are very small T1 or T2 nasopharyngeal lesions, where there are a few studies where they have done endoscopic nasopharyngectomy, and patients have had better overall survival as compared to re-irradiation alone. However, re-irradiation is a standard option in this setting as well, but there are multiple factors which determine the use of these options. So a lot of patients are not suitable for either surgery or RT and end up on systemic therapy alone. So now we go look at the role of immunotherapy in metastatic or recurrent nasopharyngeal carcinoma. Chemotherapy with GemCis is the standard which we all use in our setting. Sometimes for patients who are not fit for cisplatin, we substitute it with carboplatin. But what is the role of immunotherapy in nasopharyngeal carcinoma? So the basis of the rationale for nasopharyngeal carcinoma, the use of immunotherapy, is that it is a very immune hot tumor, because the whole pathogenesis involves because of chronic and which allows chronic or latent EBV infection, which leads to carcinogenesis. And this EBV proteins and the RNA which is there in the cells modify the cell and allow them to evade the host immune surveillance, and then that's how the tumor cell proliferates. And there is also a lot of T lymphocyte infiltration into this tumor microenvironment, and also mechanisms which interfere with antigen presentation and the subsequent immune response are seen in nasopharyngeal carcinoma. So this background for pathogenesis makes it a good tumor to use immunotherapy. So there are multiple ongoing studies with various anti-PD-1, PD-L1 agents. These are a few early phase studies which have been published. The one is with a phase 2 study with nivolumab, which is the NCI 9742 study, where they found there was an overall response rate of 20% in patients. It's a small study of only 44 patients. And these are patients who have failed standard chemotherapy, and they were given nivolumab. And around 20% of the patient, that is 9 out of this 44, received it for more than 12 months. And the 1 year overall survival was 59%. And the 1 year progression-free survival was 19.3%. And these are the responses that you can see. The color bar, so the blue bar indicates a PDL1 of more than 1%, the yellow bar less than 1%. So though this was used in all the patients, irrespective of PDL1, you can see the response rates were better, or the patients who had CR and PRs were more in those who had PDL1 levels of more than 1%. So probably patients who have better PDL1 may have better responses. We need larger phase 3 randomized studies to confirm the same. Similarly, there was a study for pembrolizumab in nasopharyngeal carcinoma. It was a stage 1B study. And again, these are the responses seen. These are small studies which need further confirmation. There are 2 new studies which were presented with 2 new PD-1 inhibitors at this year's ASCO. One is the Jupiter study, which showed toripalimab. This is a IgG4 antibody against PD-1, which is developed in China. And here they have combined it with gemcitabine for 6 cycles, and then as a maintenance for at least 2 years, as compared to our standard of gemcitabine with the placebo. And they found that this has significantly improved the overall survival as well as the progression-free survival, and also there is an improvement in the overall survival. So these are preliminary results of the study. The study is still ongoing, but this was what was presented. And if you look at the median progression-free survival, like in previous chemotherapy studies, it was 7 to 8 months. Similarly, here it is 8 months. And with the use of the immunotherapy, it is around 11.7 months. And in the overall survival, it was not reached the median overall survival in both the arms, but the 1 year overall survival was 91.6% with those who received toripalimab, and it was 87% in those who received placebo plus chemo. So probably on long-term follow-up, the benefit with the maintenance PD-1 inhibitor is becoming more apparent as time goes by, and with long-term follow-up, this benefit might, the difference might increase, and we might note a higher benefit. This is another new PD-1 agent, which is camrelizumab, which is also used in the similar manner in combination with first-line palliative chemotherapy. This is also a study which was done in China. And this was again given along with gemcitabine cisplatin, 200 milligrams, 3 weekly. And these were for both recurrent and metastatic patients, and who were fit with the ECOG PS of 0 to 1. And again, we can see there is a improvement in the progression-free survival. Both at 12 months, it was more than double. And at 18 months also, it is more than double of that, the PFS of that of chemotherapy alone. The median was 10.8 months, adding camrelizumab to gemcitabine. And gemcitabine alone was 6.9 to 7 months, like seen in previous studies. And the subgroup analysis for PFS favored the immunotherapy plus gemcitabine arm in most of the groups. So this was concluded that it significantly prolongs the PFS, and the duration of response was longer. OS they could not comment because it is immature. The median has not been reached. These are the other studies going on. There are many more studies going on in the locally advanced setting as well. 2 we have discussed. This is one which is where nivolumab is being added to gemcitabine, similar to these 2 study designs. And there's another study also ongoing, phase 2 of Nevo-Ipi, which the results are awaited. These are some immunotherapy trials which are ongoing for patients with locally advanced nasopharyngeal carcinoma with chemoradiation and being treated with a curative intent. And we are also awaiting results of these studies. So to summarize, with all this evidence, what we practice at TMH or what is commonly followed at our institute, for stage 1, it is RT alone, and it is RT that is used in standard of care is IMRT, which is also used in our hospital. The dose is 70 gray. If the patient is clinically node negative, that is stage 1, the the preferred modality is irradiating the bilateral neck because they have a higher propensity for bilateral neck metastasis, so around 50 gray to the neck. Stage 2, chemoradiation. Bulky T2 and all T3 and N plus, usually in our setup, we use induction chemotherapy followed by chemoradiation. The commonly used post-NACT concurrent chemotherapy is cisplatin. We usually use 40 mg per meter square for 6 cycles. In patients are unfit, then we use carboplatin, AUC2 instead of cisplatin. In patients who have received, suppose if somebody has received concurrent chemotherapy prior and comes to us, then we have to give them adjuvant chemotherapy in locoregionally advanced nasopharyngeal carcinoma. The choice of NACT for in our institute was DCF as well as gemcisplatin. Both are used. Now, since after the data of gemcitabine cisplatin has been published, because of easier administration and convenience of administering it in an outpatient setting, we are moving to more frequent use of gemcitabine and cisplatin, but both regimens are used. Palliative chemotherapy, gem-carbo is our first line. In second line, we have used taxane plus carboplatin, single agent taxane, and cetuximab based therapy. And immunotherapy in patients who have high PD-L1 or MSI high. The newer drugs are not yet available in India. So whether they are going to become standard of care, that is combination of the new immunotherapy agents with palliative chemotherapy, will be told in time, and access to the drugs is still not there. So in the third line setting, if the patient does well and is fit, we do use immunotherapy, cetuximab based chemotherapy. Sometimes chemotherapy with anti-VEGF with bevacizumab also has been used in our setting. So with this, I come to the end of the class. So just to summarize, a nasopharyngeal carcinoma is mainly pathogenesis-wise, it's a EBV-driven tumor. Just an important point that I missed, I didn't put slides on, were EBV monitoring or EBV-based surveillance for lack of time. EBV monitoring has been used in various settings. It has been used in endemic settings as a surveillance in patients who are at high risk to get nasopharyngeal carcinoma, and they have shown that though it doesn't change the overall survival or the mortality reduction, the patients are detected at an earlier stage. In the patients who are on treatment, EBV has been used as a prognostic marker when it is done pre-treatment as well as post-chemoradiation. And there are multiple studies which show that patients who have a decline in the EBV levels or whose EBV clears, they do better than patients with high levels of EBV after completion of chemoradiation. EBVs, there have been retrospective as well as prospective trials in the setting. And there are also trials in the setting of testing EBV in patients who have completed treatment to detect early responses. And these are ongoing. There has been no benefit in de-escalating therapy, and there is no data or evidence to suggest that we can escalate therapy right now on basis of the EBV levels. There are ongoing trials, so we have to await these results. But what we need to remember is that Epstein-Barr viral DNA level high in a patient post-treatment or very high levels, more than 4,000 copy numbers in a patient pre-treatment, are poor prognostic markers. To summarize, very early stage nasopharyngeal carcinoma, stage 1 is RT alone. Locally, regional stage 2 to 4 without METs is induction chemoradiation with induction followed by chemoradiation or chemoradiation followed by adjuvant therapy, depending on which part of the world and what is followed. In metastatic setting, palliative chemotherapy, select patients with oligometastatic disease, consolidation RT after that, and now the upcoming role of combination of immunotherapy with first-line systemic therapy, chemotherapy. And also to remember that EBV has a prognostic role. So with this, I would end the class and I'll be happy to take questions. There's only one question in the chat. Any questions anybody would like to ask? The first question on the chat is, Lingraj sir has asked if any study has been used to look into the association of EBV status and benefit of induction adjuvant therapy. I am not aware, I'll have to look up, but there are studies which are ongoing to look at patients who have higher EBV levels and whether giving adjuvant chemotherapy therapy, like in addition, after completing induction chemotherapy followed by chemoradiation, whether in patients who have persistent EBV levels, there are studies where giving additional adjuvant chemotherapy will improve in outcomes. Those studies are ongoing. We don't have any results right now to suggest that if you add additional adjuvant chemotherapy, there was one study, but it did not show an improvement in adding additional IV chemotherapy in patients who had positive DNA. So in most of the studies are from China. Other than China, I'll have to look up. In the capecitabine metronomic dosing, the failure-free survival was significant, but loco-regional free survival and distant mets were not significant. It is correct. The failure-free survival was significant. The loco-regional and distant met were not significant. And also there was a little criticism of the study that if the metronomic therapy improve the failure-free survival in patients who had received already induction therapy, whereas the other study with standard dose capecitabine, the patients had not received any prior induction or adjuvant. So whether this metronomic therapy really was, and the absolute survival values were similar in the study. So there were queries raised during the ASCO discussion whether this metronomic therapy was really beneficial, or how should it be placed in these patients who have received induction therapy. And this study has not yet shown significant changes in the loco-regional free survival, but this loco-regional free survival has not been significant in other studies also of adjuvant therapy. So probably we don't expect that to change, but distant metastasis free survival, we probably need a longer follow-up. The next question was T2N0 patients should be offered to whether they should be offered NACT. So this is a gray area. There has been a lot of debate on this. There are some trials which have excluded T2N0 patients, and in many centers, these patients receive chemoradiation alone. Also, patients with T3N0 disease are also not included in many of the NACT trials, and they are excluded and offered chemoradiation alone. So there is a little debate on this, whether the T2N0 or T3N0 patient should be offered NACT. So some guidelines recommend that they should not be offered and given only chemoradiation alone. So many times T2N0 patients are treated with CTRT alone. T3N0, there is a little bit of a controversy because T3 and bulky diseases are known to have recurrence or relapse loco-regional as well as distant. So even in the patients of T3N0, many times have been excluded in trials. So probably T2N0 patients who have high risk factors, like the ones in the adjuvant capecitabine trial, the ones who have high copy numbers, probably more than 4,000 of EBV, those patients pre-treatment might be screened for probably could be offered NACT, and we probably need more trials to answer this question. Okay, Lingraj sir's next question is role of IO and PDL1 cryptic rearrangement via NGS, a better predictor of response in NK cell lymphoma. Seems to be a better predictor. So
yeah, Nandhini, this was a comment. So as all of us know that PDL1, I think Akhil has also asked this question, that the role of IO in current setting. So this is a comment that we know that PDL1 is definitely not a better predictor for IO responses. So what there is a data that's is on a very small group of patients from Singapore, where what they have done is that they have done NGS and looked at PDL1 gene rearrangement, cryptic rearrangement in the NGS. And there they have found that those who have this gene rearrangement, that becomes a better predictor of response to IO. So that logic, what they have given is that we have two kinds of PDL1 expression. One is constitutional expression, and one is inducible expression. So constitutional is when you have a genetic PDL1 rearrangement, so where you have PDL1 expression all over, and there is something called inducible, which may not be a good predictor for response to IO. If you see Hodgkin has a constitutional genetic PDL1 rearrangement, because you don't need PDL1 level in Hodgkin, because it has a genetic rearrangement which somehow enrich the PDL1 in the tumor cells. But if you see other tumors, it is all over. So I think that may be a good way to look at in our patients by doing NGS and look at PDL1 gene. I want comment from Anita madam and Kumar sir also about their thoughts.
So, ma'am, would you like to add to it? Sir, I agree with you. PDL1 expression is even in nasopharyngeal carcinoma. There have been some studies and meta-analysis which says that like you said, the IHC expression may not be the actual marker, and they do not seem to have any impact. And probably other things like genetically or constitutionally altered PDL1 status might be important. But I didn't find anything when I looked up literature. The other things they are studying is TMB and other hotspot mutations and microsatellite instability, but they found that very small percentage, some 1% was only 1.1 had some microsatellite instability, and a very small percentage had TMB. So I'll have to look up if there are any other better markers. So there is still not a clear consensus on what is the best biomarker based on whatever data is available in nasopharynx, whatever I had looked up. And PDL1 is not known, it's known to not be a perfect marker. So they found it doesn't really correlate with the OS outcome. So you are right, sir. But Kumar sir, madam, would you like to add?
Sorry, regarding the biomarker and regarding PDL1, no, it hasn't, at least not in nasopharynx, it has not proven. But I think going to Akhil's question and the general question as to where immunotherapy is placed in nasopharynx. So this was a very exciting development, and actually this was part of the plenary session of this year's ASCO, the toripalimab, which is and very important for a couple of reasons. One is that toripalimab has been is an immunotherapy which was developed in China. So they had to, now it has got breakthrough designation in the US and it will probably get FDA approval, but it was actually, it's immunotherapy developed in China. So such a remarkable thing. And it was in the plenary of ASCO, it improved from, the PFS improved, Nandhini, from 8 to 12 months or something like that. So yes, very remarkable development. And I think, so IO is here to stay in the first line therapy for nasopharynx.
Any other questions or comments? Two more. If there are no other questions, I'll hand over to Kumar sir for the weekly discussion with the residents. Sir, over to you.
Thank you, Nandhini. Thank you. It was a nice presentation. Dr. Lingaraj, any update and you want to caution the
yes, sir. So, so as you're looking at the numbers, it is more or less stable. So it does not increase. So, but we are testing more lately. That was not there. So now we have the testing numbers have increased, but still the cases are more or less stable enough. So I would say that we have not gone into that zero number, but definitely we are getting once in a day, 1 or 2 cases, but not increasing as expected. Yes.
How many admitted?
I think, sir, around 10. So, Smita, if Susmita is there, she can tell us. So, these all are mostly the patients who are positive for long. The new patients are very less. Sir.
Okay.
Yes, sir. Yes,
sir. Dr. Jaya, suggestions for the residents? Dr. Jaya is there? So, if Dr. Jaya is not there, then again, I'll request all the residents to be careful because in Mumbai it looks like there has been some increase in numbers. Whatever I got the information from talking to people. So be careful. Let's take a precaution and continue to take precaution for some more time. And thank you all. Thank you so much. So again, requesting everyone to be careful. And thank you, Nandhini. It was a very nice presentation. Thank you.
Thank you, sir.